IA. Stage III lung cancer. Axial CT in lung windows, left image shows a right upper lobe peripheral mass arrow that abuts the pleura. There is diffuse centrilobular emphysema. Soft tissue window CT shows ipsilateral right paratracheal adenopathy arrow. The T staging is T2 for size greater than 3 cm and the N staging is N2 for ipsilateral mediastinal nodes. The overall stage is therefore IIIA and this tumor is resectable. Case courtesy. Example staging. Stage 4. Stage 4 lung cancer. Axial CT left image shows a dominant, spiculated right upper lobe T2 mass. More inferiorly, right image, a small contralateral nodule arrow is present. This nodule was determined to be malignant on follow-up, for an M staging of M1A and stage EVA disease. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Example staging. Stage 4. Stage 4 lung cancer. Axial CT left image shows a left upper lobe mass with ipsilateral hilar adenopathy arrows. Coronal CT through the upper abdomen shows bilateral adrenal masses arrows, which were confirmed to be metastasis M1C, representing stage IVB disease. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Pulmonary vascular disease. Pulmonary embolism, PE. Pulmonary embolism can be divided into acute and chronic subtypes. Acute PE is associated with the typical symptoms of dyspnea, tachycardia, and pleuritic chest pain. Chronic PE may be associated with pulmonary hypertension, further discussed in the next section. Acute pulmonary embolism clinical diagnosis. Diagnosis of pulmonary embolism, PE, can be challenging because the presenting symptoms are both common and nonspecific, including dyspnea, tachycardia, and pleuritic chest pain. Most pulmonary emboli originate in the deep veins of the thighs and pelvis. The risk factors for deep venous thrombosis include immobilization, malignancy, catheter use, obesity, oral contraceptive use, and thrombophilia. Approximately 25% of patients with PE do not have any identifiable risk factor. The Wells score assigns point values to clinical suspicion and various symptoms suggestive of pulmonary embolism. D-dimer is sensitive for thromboembolic disease and has a high negative predictive value, but is of little value in the typical inpatient population as there are many false positives. Imaging findings of acute pulmonary embolism. Pulmonary embolism. CT pulmonary angiogram shows a large, nearly occlusive filling defect in the right main pulmonary artery, arrows extending distally to the bifurcation. CT pulmonary angiogram is the most common method to image for PE, where an embolism is typically seen as a central interluminal pulmonary artery filling defect. Pulmonary emboli tend to lodge at vessel bifurcations. Pulmonary infarction can be seen as peripheral wedge-shaped consolidations often with reverse halo sign. Pleural effusions often develop after several days. After congestive heart failure, CHF, parapneumonic effusion, and malignancy, pulmonary infarct is the fourth most common cause of pleural effusion. Cardiac evaluation for acute pulmonary embolism. In patients with acute PE, one should always examine the heart for imaging findings of right heart dysfunction, which is associated with increased mortality. Findings of right heart strain include bowing of the intraventricular septum to the left. An elevated RV/LV ratio is greater than or equal to 1. Presence of right heart strain determines categorization of submissive versus massive PE. Submissive PE shows RV enlargement on imaging or clinical signs of RV dysfunction. Massive PE has systemic hypotension, less than 90 mm of mercury. Axial CT demonstrates bowing of the interventricular septum to the left arrow. The right ventricle is larger in diameter than the left ventricle. These are signs of right heart strain. Management of acute pulmonary embolism. Low-risk PE, non-massive anticoagulation, AC only or surveillance if isolated subsegmental PE with no proximal lower extremity DVT and low risk for recurrence. Intermediate risk, submissive, AC+, intervention if more moderate to severe RV strain or any acute distress. Intervention includes systemic IV thrombolysis, mechanical thrombectomy and catheter-directed therapy. High risk, massive, AC+ intervention. Intervention includes surgical embolectomy, systemic IV thrombolysis, mechanical thrombectomy and catheter-directed therapy. Plain film evaluation of pulmonary embolism. While a CT pulmonary angiogram is the standard tool to evaluate for pulmonary embolism, It is important to be aware of plain film findings that could suggest pulmonary embolism in case the diagnosis is not clinically suspected. The Fleischner sign describes widening of the pulmonary arteries due to clot. Prior radiograph. Fleischner sign. Current chest radiograph top left image shows relative enlargement of both pulmonary arteries, arrows, which is a new finding compared to the prior radiograph. Subsequently performed CT pulmonary angiogram, left image shows bilateral pulmonary emboli, arrows. Case courtesy Robert Gordon, MD, Brigham and Women's Hospital. Hampton's hump is a peripheral wedge-shaped opacity representing pulmonary infarct. Westermarck sign is regional oligemia in the lung distal to the pulmonary artery thrombus. Rounded opacity, arrow, projecting over the lingula, representing Hampton's hump. Chronic pulmonary embolism clinical diagnosis. Chronic PEs present with signs and symptoms of pulmonary hypertension, including shortness of breath exacerbated with activity, fatigue, and chest pressure or pain. Note that not all patients with chronic PE develop pulmonary hypertension. Imaging findings. Chronic PEs present as eccentric filling defects, a web, or pruning of the pulmonary artery branches. Note that resolving acute PE will involute with eccentric filling defects or webs. Parenchymal signs include mosaic attenuation from altered perfusion and occasionally scarring. In these patients, it is important to look for signs of pulmonary hypertension which include enlargement of the pulmonary artery when the PA to ascending aorta ratio is greater than or equal to 1. Right ventricular enlargement and hypertrophy. Axial CT demonstrates a subsegmental eccentric web, consistent with a chronic pulmonary embolism. Chronic thromboembolic pulmonary hypertension, CTEPH. CTEPH is the constellation of chronic PE and pulmonary HTN, subsequently discussed. Patients are often evaluated with VQ scan and CTPE since each can miss defects. CT shows eccentric organized thrombi, pulmonary artery enlargement, mosaic attenuation and vascular pruning. VQ scan shows segmental perfusion defects. Contrast-enhanced CT axial images demonstrate extensive eccentric mural thrombi involving the distal right main pulmonary artery with foci of calcification, blue arrow. Lung windows demonstrate enlarged pulmonary arterial trunk, red arrow, and mosaic attenuation of the lung parenchyma, green arrow. Pitfalls of CT pulmonary angiogram. Hilar lymph nodes and mucus-impacted bronchi may simulate PE. Unopacified pulmonary veins may simulate PE on a single CT slice. However, one may distinguish between a pulmonary artery and vein by tracing the vessel back to the heart. During the Valsalva maneuver, transient disruption of contrast bolus occurs when unopacified blood from the IVC enters the right atrium and is pumped into the lungs. This causes dense contrast to be seen in the SVC, no contrast in the pulmonary artery, and dense contrast in the aorta. On the other hand, late contrast timing would show less dense contrast in the SVC. This can be mitigated by a scan in expiration. Cardiac and respiratory motion artifacts can decrease image quality. Cardiac motion causes blurring of the left lower lobe pulmonary arteries, which may simulate small emboli. Respiratory motion decreases accuracy in evaluation of small pulmonary arteries. Pulmonary hypertension. Mosaic. Perfusion chronic thrombus. Luminal irregularity. Dilated vessels. Webs. Illustration demonstrating the physiologic changes in pulmonary hypertension. A normal lung is on the left and abnormal lung on the right. Key findings include dilated vessels with abrupt change in caliber or abrupt cutoff. Chronic eccentrically located pulmonary thrombus may be seen along the vessel walls. Webs, delicate ribbon-like structures attached to the vessel wall, are often seen in the setting of chronic pulmonary embolus. Mosaic perfusion of the lung parenchyma is due to heterogeneous perfusion. The term pulmonary hypertension encompasses both pulmonary arterial and pulmonary venous hypertension. The term pulmonary arterial hypertension (PA) is generally reserved for the WHO Class I entities primary pulmonary hypertension, discussed below. Pulmonary hypertension is pulmonary arterial systolic pressure is greater than or equal to 25 mm Hg at rest or is greater than or equal to 30 mm Hg during exercise. Elevated pulmonary venous pressures are present when pulmonary capillary wedge pressure, an approximation of pulmonary venous pressure, is greater than or equal to 18 mm Hg. Overview of pulmonary hypertension classification. There are a number of causes of pulmonary hypertension including chronic thromboembolic disease, chronic respiratory disease, chronic heart disease, and idiopathic causes. The World Health Organization (WHO) clinical classification based on the 2018 World Symposium on Pulmonary Hypertension, describes 5 groups of pulmonary hypertension. Group 1. Pulmonary arterial hypertension (PA). Primary pulmonary hypertension (PPH) may be idiopathic or familial. Congenital left-to-right shunts, such as atrial septal defect (ASD) and ventricular septal defect (VSD), may cause PA and shunt reversal Eisenmenger syndrome. Group 1. Pulmonary veno-occlusive disease (PVOD) and pulmonary capillary hemangiomatosis (PCH). PA may be caused by pulmonary venous or capillary involvement. Group 2. Pulmonary venous hypertension. Left-sided heart disease, left atrial, left ventricular, or mitral aortic valve disease may cause elevated pulmonary venous pressure in chronic disease. Group 3. Pulmonary hypertension associated with chronic hypoxemia. COPD, interstitial lung disease, and sleep apnea can cause pulmonary hypertension in chronic disease. Group 4. Pulmonary hypertension due to chronic thromboembolic disease. Group 5. Pulmonary hypertension due to miscellaneous disorders. Sarcoidosis is a rare cause of pulmonary hypertension. Compression of pulmonary vessels, which can be due to neoplasm, fibrosing mediastinitis, etc., may cause pulmonary hypertension. General imaging of pulmonary hypertension. Pulmonary hypertension. Chest radiograph shows an abnormal convex mediastinal bulge representing an enlarged main pulmonary artery, red arrow. Non-contrast CT, bottom left image, and gated contrast-enhanced cardiac CT, bottom right image, show that the pulmonary arterial atherosclerotic plaque has both calcified, arrow in non-contrast image, and non-calcified, arrow in contrast-enhanced image components. The diameter of the main pulmonary artery, PA, is clearly larger than that of the aortic root. A main pulmonary artery diameter is greater than or equal to 2.9 cm suggests the presence of pulmonary hypertension but is not highly sensitive or specific, and pulmonary hypertension may be present with a normal caliber pulmonary artery. A main pulmonary artery diameter larger than the aortic root diameter is also suggestive of pulmonary hypertension. Pulmonary artery wall calcifications are pathognomonic for chronic pulmonary artery hypertension typically seen due to shunts. Pulmonary hypertension may cause mosaic attenuation due to perfusion abnormalities, most commonly seen in chronic thromboembolic pulmonary hypertension (CTEPH). Pulmonary hypertension may be associated with ground glass centrilobular nodules, which may be cholesterol granulomas representing prior microhemorrhages. Centrilobular nodules may also be seen in PCH. An enlarged pulmonary artery can mimic a mediastinal mass. The hilum convergence sign is helpful to confirm that the apparent mass, in fact, represents the pulmonary artery. The hilum convergence sign describes the appearance of hilar pulmonary artery branches converging into an enlarged pulmonary artery. In contrast, the hilum overlay sign describes the visualization of hilar vessels through a mass. It indicates that a mediastinal mass is present, which cannot be in the middle mediastinum. Primary pulmonary hypertension (PPH) WHO Group 1, precapillary. The pathologic hallmark of primary pulmonary hypertension (PPH) is the plexiform lesion in the wall of the muscular arteries, which is a focal disruption of the elastic lamina by an obstructing plexus of endothelial channels. PPH may be idiopathic, females greater than males, or familial, approximately 10% of cases. On imaging, there is typically enlargement of the main pulmonary arteries with rapidly tapering peripheral vessels. Pulmonary hypertension due to left-to-right cardiac shunts, WHO Group 1, precapillary. Congenital left-to-right cardiac shunts, such as ventricular septal defect (VSD), atrial septal defect (ASD), and partial anomalous pulmonary venous return, cause increased flow through the pulmonary arterial bed. This chronically increased flow may eventually lead to irreversible vasculopathy characterized by pulmonary hypertension and reversal of the shunt, known as Eisenmenger syndrome. Imaging of PA secondary to a congenital shunt is similar to that of PPH. There is enlargement of the central and main pulmonary arteries, with peripheral tapering. However, radiologists should look for the presence of an intracardiac or extracardiac shunt in any patient with unexplained pulmonary HTN. Pulmonary veno-occlusive disease (PVOD) and pulmonary capillary hemangiomatosis (PCH) WHO Group 1, postcapillary. PA secondary to PVOD is caused by fibrotic obliteration of the pulmonary veins and venules. PVOD may be idiopathic but is associated with pregnancy, drugs especially bleomycin, and bone marrow transplant. Imaging features interlobular septal thickening, patchy or centrilobular ground glass opacities, pulmonary arterial enlargement, mosaic attenuation, and pleural effusions. PCH is an entity that involves capillary proliferation leading to pulmonary hypertension in children and young adults. Pulmonary venous hypertension, WHO Group 2, postcapillary. Left-sided cardiovascular disease leads to elevated pulmonary venous pressure, which is a cause of pulmonary hypertension. Most common etiologies are left ventricular systolic and diastolic dysfunction and valvular disease. Pulmonary hypertension associated with hypoxemic lung disease, WHO Group 3, precapillary. COPD, sleep apnea, and interstitial lung disease can all lead to pulmonary hypertension. Chronic hypoxic vasoconstriction is thought to invoke vascular remodeling leading to hypertrophy of pulmonary arterial vascular smooth muscle and intimal thickening. Chronic lung disease can further contribute to obliteration of pulmonary microvasculature through emphysema and the perivascular fibrotic changes of pulmonary fibrosis. Chronic thromboembolic pulmonary hypertension, CTEPH, WHO Group 4, precapillary. Chronic occlusion of the pulmonary arterial bed can lead to pulmonary arterial hypertension, which is a complication affecting 1–5% of patients who develop acute pulmonary embolism (PE). Of note, many patients with CTEPH never had previously diagnosed acute PE. VQ scan or CT pulmonary angiogram are typically done as part of the workup for new diagnosis of pulmonary HTN to rule out CTEPH. Features of chronic PE are described previously. Mosaic attenuation is typical. Treatment of CTEPH is surgical pulmonary thromboendarterectomy or balloon pulmonary angioplasty. Fibrosing mediastinitis, WHO Group 5, postcapillary. Coronal CT. Coronal CT. Nuclear medicine perfusion scan. Fibrosing mediastinitis. CT shows dilation of the main and right pulmonary arteries, yellow arrows. There is a partially imaged right lower lobe pulmonary artery stent, red arrow. Indistinct soft tissue, blue arrows, encases the right upper lobe pulmonary artery, which is narrowed and distally dilated. Mediastinal soft tissue with calcified lymph nodes, green arrows, can be seen posteriorly. Nuclear medicine perfusion scan shows markedly heterogeneous pulmonary perfusion, with near absence of perfusion of the right upper lobe, white arrow. Progressive proliferation of fibrous tissue within the mediastinum may lead to encasement and compression of mediastinal structures. The most common causes of fibrosing mediastinitis are histoplasmosis and tuberculosis. Fibrous encasement of the pulmonary veins leads to permanent histological changes within the endothelial cells. Fibrosing mediastinitis may also encase the pulmonary arteries, creating a pre-capillary pulmonary hypertension. Imaging features of fibrosing mediastinitis include increased mediastinal soft tissue, often with calcified lymph nodes due to prior granulomatous infection. Diffuse lung disease. Interstitial lung disease. Overview of interstitial lung disease. Interstitial lung disease (ILD) may be idiopathic, or secondary to known insults which include drug toxicity, collagen vascular disease, or occupational exposure. A disease can only be classified as an idiopathic interstitial lung disease if there is no other explanation for the pathologic changes. Non-specific clinical symptoms of ILD consist of cough and dyspnea, however factors such as age, gender, risk factors, course of disease, and imaging features can help distinguish between the various entities. Histologically, the lung responds to injury by recruiting lymphocytes or macrophages, increasing inflammatory debris, and instigating a fibrotic reaction. There are 8 entities which fall under ILD. The pathologic entities may have different clinical syndromes. Histologic pattern clinical correlate main imaging findings. Usual interstitial pneumonia, UIP. Idiopathic pulmonary fibrosis, IPF, rheumatoid arthritis. Asbestosis. Drug toxicity. Basilar subpleural reticulation with honeycombing. Nonspecific interstitial pneumonia, NSIP. Scleroderma. Dermatomyositis. Mixed connective tissue disease drug toxicity. Parabronchial reticulation, traction bronchiectasis, plus ground glass opacities. Organizing pneumonia. Cryptogenic organizing pneumonia, COP idiopathic. Drug toxicity. Connective tissue disorders, particularly SLE and dermatomyositis. Peripheral or parabronchial ground glass or consolidative opacities. Respiratory bronchiolitis, RB, smoking-related spectrum upper lobe centrilobular nodules desquamative interstitial. Pneumonia, DIP, smoking-related spectrum lower lung predominant ground glass. Lymphoid interstitial pneumonia, LIP. Sjogren's syndrome. Immune dysregulation including HIV and CVID nodules and cysts. Diffuse alveolar damage (DAD). Acute interstitial pneumonia (AIP), acute respiratory distress syndrome (ARDS), transfusion-related acute lung injury (TRALI), diffuse airspace disease. Hypersensitivity pneumonitis (HPDH). R, Y, U, P, G, T, S, O, E, SHE, N, C, SI. IVT pneumonitis acute. Extensive ground glass and air trapping chronic, ground glass, parabronchial fibrosis. Usual interstitial pneumonia UIP. Idiopathic pulmonary fibrosis IPF is the clinical syndrome of UIP with unknown cause and is the most common cause of UIP. IPF has a much worse clinical outcome compared to secondary causes of UIP. The mean survival of IPF is not much different compared to lung cancer. Of all the interstitial pneumonias, only acute interstitial pneumonitis AIP has a worse prognosis. Clinical symptoms of IPF include dry cough and dyspnea. IPF usually affects male patients greater than 50 years old, and typically smokers. Other triggers of lung injury that may result in a UIP pattern include collagen vascular disease, rheumatoid arthritis much more commonly than scleroderma, drug toxicity, asbestosis. An imaging clue to the presence of asbestosis is calcified plaques indicative of prior asbestos exposure. The pathology of UIP features interstitial fibroblastic foci and chronic alveolar inflammation with temporal and spatial heterogeneity. Non-contrast CT shows subpleural reticulations and honeycombing arrow. Early UIP features reticulation in the posterior subpleural lung bases. In later stages of UIP, traction bronchiectasis and subpleural honeycombing develop. The lung bases are the most severely affected. Surgical biopsy can be avoided if characteristic features, in particular peripheral basal location of reticulation, are present. The American Thoracic Society (ATS) developed updated guidelines in 2018 for how to characterize a UIP pattern on court. Nonspecific interstitial pneumonitis (NSIP). NSIP. Axial CT shows posterior basal predominant subpleural and parabronchial reticulation, mild ground glass attenuation, and mild traction bronchiectasis. This presentation likely represents the fibrotic subtype of NSIP. Esophageal dilation arrow is a clue to the presence of scleroderma, which is often associated with NSIP. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Nonspecific interstitial pneumonitis (NSIP) is both the name of the clinical syndrome and the corresponding pathologic diagnosis. Affected patients are typically younger, 40 to 50 years old, compared to IPF. Symptoms are similar to IPF with chronic dry cough and dyspnea. NSIP has a better 5-year survival compared to IPF. Unlike IPF, NSIP does respond to steroids. NSIP is almost always associated with an underlying disease. NSIP is the most common pulmonary manifestation in patients with collagen vascular disease. NSIP may be associated with dermatomyositis, SLE, mixed connective tissue disease, and scleroderma. NSIP may also be caused by drug reaction. Histologically, NSIP features thickened alveolar septa from chronic inflammation, in contrast to IPF, UIP. An important imaging feature of NSIP is the presence of ground glass opacities, GGO, with parabronchial predominance, which is a key feature to distinguish NSIP. A key imaging finding, not always seen but very specific, is sparing of immediate subpleural lung. This feature is not seen in UIP. Like UIP, NSIP tends to affect the lower lobes. Other diagnoses should be considered, e.g., chronic hypersensitivity pneumonitis or sarcoidosis if there is primarily upper lobe disease. Organizing pneumonia (OP). Axial CT shows patchy consolidative and ground glass opacities in a parabronchovascular distribution. There is a reverse halo or atoll sign in the right lower lobe arrow where a central lucency is surrounded by a peripheral opacity. Case courtesy Seth Klegerman, MD, University of Maryland. Organizing pneumonia is the histological pattern of alveolar inflammation with granulation tissue polyps that fill the distal airways and alveoli. OP may be a response to infection, drug reaction, or inhalation. OP may be idiopathic or related to connective tissue disease as well. Cryptogenic organizing pneumonia, COP, is idiopathic OP, previously called bronchiolitis obliterans organizing pneumonia, BOOP. COP clinically responds to steroids with a good prognosis and may resolve completely, although recurrences are common. CT shows consolidation or ground glass opacities in a peripheral and parabronchovascular distribution. The reverse halo sign, also known as the atoll sign, features a central lucency surrounded by a ground glass halo. Reverse halo sign is not specific but in the appropriate context is highly suggestive of OP. The reverse halo sign should not be confused with the halo sign that is typical of invasive aspergillus, which shows a central opacity with peripheral ground glass. Respiratory bronchiolitis, interstitial lung disease (RBILD). Axial CT shows innumerable subcentimeter centralobular nodules of ground glass attenuation (arrows). None of the nodules extend to the pleural surface, which is typical of a centralobular distribution. This was a case of respiratory bronchiolitis interstitial lung disease (RBILD). Respiratory bronchiolitis, interstitial lung disease (RBILD) is both the clinical syndrome and the pathologic diagnosis of this smoking-related interstitial lung disease. Respiratory bronchiolitis (RB), without the ILD, is common in smokers, where pigmented macrophages are found in respiratory bronchioles. RB is usually asymptomatic, but if symptomatic, usually cough and shortness of breath, the clinical syndrome is called RB-ILD. Histologically, RBILD is characterized by sheets of macrophages filling the terminal airways, with relative sparing of the alveoli. The key imaging features of RBILD are centralobular nodules in the lung apices. Desquamative interstitial pneumonia (DIP). DIP. Axial CT shows extensive ground glass opacities. This is a nonspecific pattern. Case courtesy Ritu R. Gill, MD, MPH, Brigham and Women's Hospital. Like RBILD, desquamative interstitial pneumonia (DIP) is both the clinical syndrome and the pathologic diagnosis. Pathologically, RB, RBILD, and DIP represent a continuous spectrum of smoking-related lung disease. Like RB, brown pigmented macrophages are involved in DIP, however, sheets of these abnormal macrophages also extend into the alveoli in DIP. Imaging of DIP shows diffuse basal predominant ground glass opacification. Although the predominant abnormality is ground glass, a few cysts may also be present. Acute interstitial pneumonia (AIP). Acute interstitial pneumonia (AIP), representing idiopathic diffuse alveolar damage (DAD), is the pathologic diagnosis seen in the clinical syndrome of acute respiratory distress syndrome (ARDS). Unlike the other IIPs, AIP is the only syndrome with an acute onset and has the worst prognosis. Two phases of AIP are recognized: early exudative and chronic organizing. The early exudative phase features hyaline membranes, diffuse alveolar infiltration by immune cells, and noncardiogenic pulmonary edema. AIP early or exudative phase axial CT shows extensive geographic ground glass attenuation. This is a nonspecific pattern and may represent pulmonary edema, hemorrhage, infection, or ARDS AIP. Case courtesy Seth Klegerman, MD, University of Maryland. The chronic organizing phase features alveolar wall thickening due to granulation tissue. The chronic phase usually begins 1 week after the initial injury. On imaging, opacities coalesce with architectural distortion and bronchial dilation. These features will resolve over time, sometimes with residual fibrosis. Antigen and exposure-related lung disease. Most inhalational lung diseases predominantly affect the upper lobes because the lower lobes have more robust blood flow and lymphatic drainage. Hypersensitivity pneumonitis (HP). Hypersensitivity pneumonitis (HP) is a common lung disease caused by a hypersensitivity reaction to inhaled organic antigens, such as bird proteins or thermophilic actinomycetes, although a history of antigen exposure is not elicited in about 1/3 of patients. HP is characterized by two clinical courses: acute, subacute and chronic. Chronic has progressive symptoms plus acute exacerbation, and fibrosis. Acute, subacute may have recurrence but no fibrosis. Acute, subacute HP is characterized by inflammatory exudate filling the alveoli, which manifests on imaging as nonspecific ground glass or consolidation. Small, ill-defined centralobular nodules and ground glass can also be seen. Mosaic attenuation, geographic areas of relative lucency, can be secondary to mosaic perfusion on inspiration and air trapping on expiration. HP. Diffuse ground glass opacities affecting both lungs with mosaic attenuation. There are diffuse small centralobular nodules (arrow). This was a case of acute, subacute HP. Chronic HP, from long-term exposure to the offending antigen, leads to pulmonary fibrosis, typically but not always upper lobe predominant. Often the findings of acute, subacute disease, including centrilobular nodules, ground glass, and mosaic attenuation, may be superimposed. Symptoms may follow a chronic, progressive course or present as multiple exacerbations. The key feature of chronic HP, in either case, is fibrosis. Fibrosis is typically parabronchovascular. The head cheese sign describes the combination of patchy ground glass and areas of lucency due to air trapping. Unlike IPF, honeycombing is not common in HP, but when present may involve the upper lobes. Pneumoconiosis. A pneumoconiosis